Thank you so much, Vardhaman, for allowing me to be a part of this course. I'll touch upon what was available earlier and what is probably what I would suggest is state of the art, and we'll also discuss some surgical results of trials that have been done. Praveen covered a lot of what I thought would be appropriate, so it makes my life easier. But with any, I'm sure you've seen this graph, at least in the Adler physiology book, which we studied in the first year, where the amount of accommodation and the range of vision for a person reduces as a person goes older. And that's something that you need to try and correct. And there are, of course, multiple described ablation patterns earlier. The first ablation pattern was to create a multifocal cornea where you had a bit of central myopia, and that's what the ablation did. It created a bit of a central myopia by about diopter, and that helped the patient to see well. But invariably, whenever you touch the cornea, you always lose distance vision. So there was a drop in the distance vision when this was achieved. There have been two important developments which took over in the late 2010 to 12, where there was a lot of talk about supracore and intracore, which are predominantly very different options. In supracore, you aim to create central islands of unablated cornea, which was something that people avoided initially, and you do it after a LASIK flap, and it is used for myopes and ametropes also, and you could basically give them about a diopter of accommodation or a diopter of reading vision. Intracore was a different procedure which used femtosecond lasers to they were intrastromal ablations which were concentric in the mid peripheral cornea, which steepened the central part of the cornea, which also gave about a diopter. And the problem were both these was they were centered on the pupil, and a lot of these patients used to have glare and halos because of the ablation patterns, and this was usually done in the non-dominant eye. Dominance, which Praveen touched upon, was where you adjust the laser procedure as per the age and the requirement of undercorrection or overcorrection, and there is something, a new term called blended vision, which I would also further touch upon. When a laser vision actually is done, there are a number of mechanisms that take place. One is you do try and induce a bit of micro monovision. The depth of the field is reduced, and there is, of course, trying to control the spherical aberrations. But simultaneously, when you do something on the cornea, and we do know that there is a concurrent change in the patient's brain, there is a bit of retinal image processing which patient undergoes. There is a bit of neural summation which the patient tries to adjust to, and this is a constant process. There is blur adaptation where the patient tends to adjust to which level. If distance vision, which eye gives distance vision, the brain would automatically adjust, and there would be an associated neural suppression. Now, for a full range of vision, for a 60-year-old or a person who's ametropic at 40, the amount of vision required, the accommodation would vary. For a full range of vision, an increased depth of field of roughly 3 diopters is ideal, which gives you a reading vision about 30 to 40 centimeters. And this includes basically the far distance, and distance is basically for car driving, intermediate, which is basically computer, screen and dashboards, and near, which is books and cell phones. A realistic increase in the depth of field, basically up to 1.5 diopters, is realistic, which gives this patient the field of vision. Then remember that you do lose a bit of near vision, because at 1.5 centimeters your reading distance goes up to almost about 60 centimeters. So there is a bit of loss of visual acuity. What you can do is basically to increase the depth of field with the help of spherical aberrations, and that is one of the reasons that I prefer negative spherical aberration lenses, because that helps to basically improve your intermediate vision, and you can adjust that with a bit of myopia. And with spherical aberration, you increase the circle of least confusion and give them an area where they can use for near vision. Combining the increased depth of field and monovision basically gives you good distance vision, and this is something that this concept has come over the last couple of years, where they talk about a blend vision, where the dominant eye has some area of intermediate and some area of distance, and the non-dominant eye has intermediate and near vision. And this concept is basically different from the traditional monovision, where you have a loss of distance vision and some loss of near vision, and your blend zone is more restricted. So this is something called a blur zone where the patient actually does not see. If you have, especially in IOLs, where you correct the dominant for distance and correct one eye for near, you lose some part of your working distance in between. The laser blended vision, as it's popularized by Zeiss, is basically incorporates a number of mechanisms. You have something called a micro monovision, which the dominant eye gives planar for distance, and dominant eye is myopic for near vision, roughly about a diopter, which was discussed earlier. The depth of field is also tried to increase. You get binocular vision without the adaptation, and the depth of field basically compensates for the lack of accommodation that is there in these patients. You do definitely try and control the spherical aberrations. Remember, every time you create a flap or ablate the cornea, you do have some spherical aberrations increase. We found in a small study which we had done about 6 years back, the amount of aberrations increased after laser ablation is usually about 0.2 to almost minus 0.5 microns. There are concurrent changes, as I mentioned. You do have some retinal imaging processing which causes edge detection, the neural summation, the blur adaptation, and neural suppression, which occurs after any surgical procedure, continues in this. The Presbyopia, which is basically marketed by Zeiss, gives you larger optical zones, and basically it also tries to adjust the high order aberrations in terms of individualized treatment that does help the patient see better. This is the graphic user interface in the machine that you actually enter. You have both the right and the left eyes entered at the same time, and you also try and adjust for the higher order aberration. So you do need an aberrometric study in this patient prior to surgery. You look at the functional age and you look at the optical zone. This is important because minimum optical zone for most laser procedures recommended is about 6 millimeters. This is just some of the clinical outcomes which were given to me by Zeiss in terms of the amount of myopic presbyopes. So they do have good near and distance vision. They are better, and the range is almost from 90 to almost about 99%, both for reading and for distance. And the real test of any laser correction is more in terms of hyperopes. So in hyperopia, the results are less better, but they are still impressive in terms of how many of these patients could read a newspaper which is roughly about J2 and see well for distance, which is a car driving a car. There are, of course, another set of patients which are emetropic, who are 40 plus, who are good for distance but require some reading vision, and in terms of satisfaction and in terms of visual results, they are still about 90%. And remember that most laser vision correction would also be about 87 to 90% even in the best of laser machines, and I'm talking about high repetitive rate machines. So you need to have something which is good for all distances. You need to have good visual acuity. You need to have something called a unique blend zone, which covers distance and near vision. There is no loss of stereo activity and especially contrast sensitivity, which is important for driving at night. In summary, in terms of laser vision corrections, a lot has changed. The way we try and approach presbyopic patients is changed. Of course, multiple ablation patterns, but the present option is where you have both customized for more distance and near vision, and you have something called a blend vision, which gives you your working distance between roughly about 35 to 50 centimeters. Thank you so much, and I look forward to also knowing from other people who have done a lot more experience, especially Vardhaman. I'm sure you do have some experience with that.